All right, welcome to the deep dive. Today, we're ripping into something that might sound pretty straightforward, maybe German measles, but, dig just a little, and you find it holds some seriously profound implications. We're diving deep into rubella.
Yes, rubella.
And for this, we've got material provided by you, the listener specifically, MSRA revision notes on rubella.
Great stuff.
Our mission, to take these notes and, well, turn them into a crystal clear, high-yield review, pulling out those core facts you absolutely need.
Exactly, because what seems like, just a mild childhood rash,
Yeah.
it's anything but simple when it comes to pregnancy.
Right.
So we're going to unpack these points, connect the dots, try and make this information really stick for you.
Yeah, not just listing facts, but getting the story, especially why prevention is just so critical.
That's the aim. Highlighting essentials, making those connections clear.
Okay, let's unpack this. So right off the bat, what is rubella at its core?
It's a viral infection caused by the rubella virus. Pretty specific name there.
And German measles is the common name, yeah. Gives you a hint about the rash.
It does. And the absolute key takeaway, the thing you need to remember right away is this. Usually, for most kids, it's a very mild illness. But, and this is the huge but, it can cause severe, really devastating issues if a woman catches it during pregnancy.
Got it. Mild for most, potentially life-altering in pregnancy. That contrast is key. What about the basics, like when it tends to appear?
Well, the notes say outbreaks are more common in winter and spring, and the incubation period, so the time from catching it to symptoms showing is typically 14 to 21 days.
2 to 3 weeks. So you might not know you've been exposed for a while.
Exactly. And this next bit is crucial for understanding how it spreads, how we control it, the infectious period. When are you actually contagious?
Okay.
This is the tricky part. You're infectious from about 7 days before any symptoms appear, specifically before the rash, and you stay infectious for about 4 days after the rash has started.
Wow, so a whole week before you even know you're ill.
That pre-rash infectiousness, that's why it's so hard to contain without good population immunity. People are spreading it unknowingly.
Right. Contagious before the signs, which leads nicely to why, thankfully, it's now pretty rare here in the UK.
Yes, exactly. Down to the MMR vaccine, its uptake means rubella is uncommon now. It's also a notifiable disease here.
Meaning cases have to be reported.
Yes, helps with tracking and public health measures.
Okay, that infectious period timing before the rash, after it starts, that feels like something to really flag in your memory. Picture that timeline. All right, let's get into the how, the etiology. We know it's the virus, but how does it actually spread?
The main way is respiratory droplets. So, coughs, sneezes, the virus traveling through the air.
The classic viral route.
Precisely. But the other absolutely critical route, the one that explains that whole pregnancy issue, is direct transmission from mother to her unborn child across the placenta during pregnancy.
Which perfectly sets up the risk factors. Who's most vulnerable?
The notes are very clear. The biggest risk factor by far is just being unvaccinated. Simple as that. No MMR, no previous infection, you're susceptible.
And zooming in on that, unvaccinated pregnant women are highlighted because of the risk to the baby.
Absolutely. Their risk profile is completely different because of those potential consequences. Other factors mentioned are people with weakened immune systems and obviously close contact with someone who's infected.
What's fascinating here is how vaccination status just completely changes the game, doesn't it? Especially for pregnant women. Transforms a mild illness into this major threat.
It really does. It's the primary defense.
Okay, let's get into the engine room pathophysiology. What does the virus actually do inside the body? Where does it start?
So the notes explain it initially targets the lining of your airways, the respiratory epithelium, and also the local lymph nodes.
So breathe it in, hits the throat, nearby glands.
Pretty much.
Yeah.
Sets up shop there in those immune system hubs.
And then, how does it spread?
From there, it gets into the bloodstream, goes systemic, travels throughout the body, and that's what leads to the general symptoms and eventually that characteristic rash.
Here's where it gets really interesting and serious. The pregnancy impact. This spread you mentioned, that's why rubella isn't just a trivial rash, right?
Yes, this is the absolute core of the problem. That ability to travel in the blood means the virus can cross the placenta. It can directly infect the developing fetus.
Leading to congenital rubella syndrome, CRS.
Exactly, CRS. That's the critical outcome in pregnancy. The virus interferes with how the baby develops, causing specific malformations. The notes list cardiac issues, the heart.
Right.
Ocular, the eyes, central nervous system, brain, spinal cord, and skeletal system, too. Think about a virus disrupting how the heart or eyes form. It's profound damage.
That sounds utterly devastating. And the notes mention this is still a significant issue globally.
It is, particularly in places with lower vaccination rates. It highlights a huge health disparity because even if the mother has mild symptoms, or none at all, the virus crossing that barrier is the game changer for the fetus.
So if someone does get rubella, what does it actually look like, the clinical features?
For most people, especially kids, it's usually mild.
Yeah.
The notes mention things like a low-grade fever, maybe a headache, mild conjunctivitis, that sort of pink eye, a loss of appetite, runny nose, and then that characteristic, usually mild, rash.
And the rash itself, it has a typical pattern, doesn't it? It doesn't just pop up everywhere.
No, it starts quite subtly, usually behind the ears and on the face first, then it spreads downwards over the trunk and out to the arms and legs.
Like it's rolling down the body.
Kind of, yeah. And swollen lymph nodes, lymphadenopathy, very common. The notes point out the classic spots to check: cervical nodes in the neck, suboccipital at the back of the head, and postauricular right behind the ears.
Makes sense given where the virus starts, in the lymph tissue.
It does. Other general sort of constitutional symptoms, usually mild, but adults might feel a bit more run down than kids. The notes also mention arthralgia joint pain, which is more common in older patients.
Okay.
And four-timer sign, those little red spots on the soft palate. They can occur, but they're not, diagnostic on their own, not specific enough.
And just to hammer it home, these symptoms, usually mild in children and adults, are totally different from the severe complications in babies infected during pregnancy.
Worlds apart.
For remembering those physical signs, maybe picturing the rash starting behind the ears and running your hands over your neck, behind the ears, back of the head for those nodes, might help link it visually.
Good tip.
Thinking about how this presents and knowing it can be mild or look like other things, that brings us to the challenge. Differential diagnosis. What else could this be mistaken for?
Ah, yes. This is where it gets really tricky clinically, because the symptoms can be, fleeting, and they mimic so many other conditions, just relying on symptoms, unreliable. The notes give a really broad list.
It's quite the lineup. You've got other common viral things with rashes, like measles itself or roseola.
Yes, exactly. And then a whole lot of other viruses: parvovirus B19, that's fifth disease, certain herpes viruses, enteroviruses, adenoviruses, CMV, even HIV or hepatitis sometimes, plus echovirus, Coxsackie virus.
And with people traveling more, you can't just think about UK viruses, can you?
Absolutely not. The notes specifically mention tropical viruses, things like alpha viruses, flaviviruses, so West Nile, dengue, chikungunya, Zika. If someone has a rash and travel history, these have got to be on the list.
Wow. And it's not just viruses either.
No. Other infections like scarlet fever, brucellosis, Kawasaki disease, even syphilis or toxoplasmosis are mentioned.
And drug reactions, too.
Yes, don't forget non-infectious causes. Drug reactions can cause rashes, sometimes linked to things like glandular fever treatments or certain anti-epileptics.
Blimey, that is an extensive list. If you're revising, how do you even begin to keep those straight? Maybe grouping them helps, like viral bacterial drug reactions.
That's exactly the sort of strategy you need, yes. Trying to just memorize the whole list cold is really tough. Grouping them, or maybe a mnemonic for the key ones you really can't miss, like measles, roseola, parvo, scarlet fever, that's a good approach.
So given that massive differential, clinical diagnosis is shaky. How do we actually confirm it is rubella? Investigations.
Yeah, as the notes stress, you need the lab confirmation. You can't just guess based on symptoms.
And the gold standard tests are?
Serology, looking for specific rubella antibodies in the blood, and/or PCR testing polymerase chain reaction, which actually detects the virus's own genetic material.
And these aren't tests you just run anywhere?
No, typically done via your local health protection unit, the HPU. They handle the public health side, too.
Any clues from routine bloods, like a full blood count?
Well, an FBC might show a low white cell count, maybe with more lymphocytes. Thrombocytopenia, low platelets can happen, too, but it usually gets better on its own. But, these are non-specific. They don't diagnose rubella.
And if you suspect congenital rubella syndrome during a pregnancy,
then you'd need more specific investigations. Things like detailed ultrasound scans looking for fetal problems, maybe genetic testing as part of the workup.
Okay, so someone has confirmed rubella. What's the treatment? How do we manage it?
This is another really key point from the notes. There's no specific antiviral treatment that actually targets the rubella virus itself.
So no magic bullet cure.
Correct. Management is all about symptomatic relief. helping the person feel better while their immune system clears the infection. So, rest, fluids, hydration, and antipyretics for fever.
And that important note about aspirin in children.
Yes, standard advice for viral illnesses in kids, but always worth repeating. Avoid aspirin because of the risk of Ray's syndrome. Use paracetamol or ibuprofen instead.
Right. And beyond managing the individual symptoms, there's the public health side.
Absolutely. A major part of management is controlling the spread.
Keeping infected kids away from school and nursery.
Exactly. The notes specify excluding them for 5 days after the rash first appears. Helps prevent passing it on, although remember they were infectious before the rash too.
And managing suspected cases in pregnant women. That needs special handling.
Definitely. Given the serious potential outcomes for the baby, the notes stress that suspected rubella in pregnancy needs thorough investigation and expert support infectious disease specialists, obstetricians.
Let's talk about the downside complications. We focused heavily on CRS, but what else can potentially happen?
Well, in children and adults, although it's usually mild, complications can happen, thankfully rare, but possible. The notes list things like encephalopathy, brain inflammation.
Serious.
Yes. Arthritis or arthralgia, joint pain or inflammation. Thrombocytopenia, those low platelets again. And Guillain-Barré syndrome, the neurological condition.
Some of those sound quite significant, even if rare.
They are. Important to be aware of them. Panencephalitis is mentioned as extremely rare, too.
And then back to the main complication, pregnancy.
Yes, this is where the major impact is. Congenital Rubella Syndrome, CRS, severe birth defects. The notes really emphasize that infection early in pregnancy carries the highest risk for defects or even miscarriage.
And CRS specifically hits which parts of the developing baby?
Primarily the eyes, causing visual impairment, blindness, hearing deafness, the heart, congenital heart defects, and the brain leading to intellectual disability, other developmental issues. These developmental problems are sadly common in survivors of CRS.
If we connect this back, understanding these specific devastating complications, it just really hammers home why prevention is so unbelievably critical, why vaccination matters so much.
Precisely. It's not just about dodging a rash, it's about preventing irreversible harm. The downstream effects are the real tragedy here.
So pulling it all together, what's the overall outlook? The prognosis.
The notes draw a very clear line. For children and adults who get rubella, generally good prognosis, usually a self-limiting mild illness.
But that huge caveat remains.
Absolutely. Because of the risk of CRS, the prognosis for the fetus is poor if the mother gets infected, especially early on, leading to those severe lifelong birth defects.
Which brings us, logically, to the most critical section, the absolute key takeaway, prevention. How do we stop this happening?
Right. The cornerstone is vaccination, the MMR vaccine, measles, mumps, rubella. In the UK, the schedule is 2 doses. First one in the second year of life, around 12, 13 months. And a booster dose around age 3 or 4 before school, usually. The notes are very clear. MMR is safe and highly effective.
What else? Screening pregnant women.
Yes, that's another key strategy, checking their blood to see if they're already immune to rubella, checking their susceptibility.
And if a pregnant woman isn't immune, you can't give her the MMR then because it's a live vaccine.
Correct. Live vaccines generally aren't given in pregnancy, so the plan is to make sure those non-immune women get the MMR after they've delivered, protects them for the future, and stops them potentially spreading it.
And repeating that public health measure.
Yes, excluding infected kids from school or childcare for 5 days after the rash appears helps break that chain of transmission.
So what does this all boil down to? It means that while rubella might sound minor, its potential impact in pregnancy is just so severe, so lasting. It makes prevention utterly crucial. Vaccination, identifying susceptible people, it really is the best approach here.
And recognizing that huge differential diagnosis list is key too, isn't it? Especially with travel or unvaccinated patients. Can't just dismiss a rash.
We really hope this deep dive into your revision notes has helped clarify rubella, making those key facts high yield and hopefully more memorable for your studies. You've got the definition, cause, risk, mechanism, presentation, epidemiology, differentials, tests, management, complications, prognosis, and crucially, prevention. And maybe a final thought, building on that epidemiology point. How might increasing global travel keep challenging our control of diseases like rubella, even here in the UK, with good vaccination rates?
It's a constant reminder, isn't it? Why maintaining that herd immunity is so vital. The virus can always arrive from elsewhere.
We hope this has been helpful. For more resources to boost your MSRA revision, remember to check out PathMSRA.com and also FreeMSRA.com.